It's a great honor to give this session. Very informal, obviously. Most of you or your family members are affected. And I have to say that different clinics and different physicians may have different approach of treating melanomas. There are a few things are common, though. You may have been treated differently, different advice about radiation or enucleation. But there are some clear data that supports what we do. So, we are moving towards data-driven lifestyle, evidence-based medicine, consensus guidelines, those kind of things. So I want to show the basis or framework of how we kind of work in our clinic and how we come to a diagnosis, or how do we come to advising people what is the best treatment for them. So just a few slides, and then we'll take questions and just move on to the next session. So overall, I know we treat melanoma, and this will be covered more in detail tomorrow. The idea, though, is to treat not just the eye or the melanoma in the eye, but overall aspects of mortality. And this is the area of discussion and research and the new frontier for tomorrow's discussion. But always remember, that's kind of what we're trying to do, although we may not be achieving a whole lot in that aspect. But if you come back to the choroidal melanoma, and this includes some of the ciliary body melanomas, but does not include the iris melanomas. So if you look at uveal melanoma, you have three kinds of uveal melanoma: iris melanoma, ciliary body melanoma, and choroidal melanoma. Most of it is choroidal melanoma, about 85%. And if melanoma is large enough, it may go from iris to ciliary body to choroid, or the other way around. So it's not confined necessarily only to one structure. But overall, choroidal melanoma is the biggest one. And that's why a big study was done, COMS, that finished approximately almost, I think, 10 years ago now, collaborative ocular melanoma study that was limited to choroidal melanoma. And this was the first prospective study that had some randomization built into it and was very scientifically very rigorous. And the quality of data coming out of this study even now is high quality. So when you read on the internet, or you read Facebook or wherever, you will find things that are not necessarily based on high quality science. So data also has to be evaluated as to where it's coming from and is based on what. So in my mind, there isn't a better quality data. This is prospective, multi-center data on hundreds of patients, hundreds of patients. The medium-sized group had 600 patients, large one had 400 patients, and small group approximately 150. So there are 1,000 patients of choroidal melanoma were treated across, I think, 35 or 40 centers in the United States and Canada. So it's not just one doctor or one person, many people doing the same thing, following the same framework, and then collecting data as to what's happening to the patients over time. That's the best quality data, okay? So I use that classification, and you say, oh, you may have a small melanoma, you may have a medium melanoma, or you have a large melanoma. And so that if we have our own data later on, then we can relate to this study or this framework. Otherwise, your large and my large and your small and my medium has different numbers. And that's one big problem with literature on uveal melanoma. One study has tumors, they say, oh, this size, but that's different from the other study and other study. And we know size matters a lot. So if you go to the doctor, and so currently if you're having treatment or newly diagnosed, you really want to know the size of it. And the size is estimated by examination, by photography, by ultrasound. So three things. You make a very good estimate about the size. And the size is therefore important, and based upon the size of the base and the height. Both together, you kind of divide into small, medium, and large. And so let's come to the small first, let's say. So if somebody has a small melanoma, but how would you manage it? How do you even diagnose it? And that's a little bit of a challenge, because in this study, even when you call them small melanomas by the size, 2/3 are actually just freckles or moles or nevi. So although you call them melanomas, most of them actually will not grow if you just follow them, at least in this study. So we know that small melanomas are not necessarily all melanomas. Some are just large nevi. And how do you tell them apart? Well, you can't really tell them apart 100% because histology, you're not going to remove the eye. Biopsy, needle biopsies may or may not give you good answer based on cytological evaluation of certain cells. So you're kind of stuck with whether it's growing or has features that tell that it may grow in the future. So growing tumor, something over 3 months or 6 months, pretty much goes along with melanoma. You wouldn't expect a freckle or a nevus to grow in 3 to 6 months. So if you have this evidence, a photograph that shows that it has grown, and that's a proof for me, I don't need any other proof that it's a melanoma. So growth is very critical. And in some cases, you don't have the growth, but you have things that tell us that this is a growing tumor. Well, that's kind of prediction for the future, and that's not 100% reliable. So there could be an error this way or that way. So you look at this and say it has features that tell us that it may be growing, or it has a feature that tells us this is a stable lesion. So that's just a relative differentiation. It's not 0% or 100%. You can say 60% it's melanoma, 80% it's melanoma, but you can never say it's 100% it's melanoma. So therefore, this component of observation was built into the small melanoma, which is still true. So there's many patients that up front we think, well, it's the size-wise, it's a small melanoma, but I think it's a freckle or nevus, we'll watch it. And since it's not affecting vision, and if we say growth happens in 3 months or 6 months, then we'll treat it. I think that's a very reasonable approach. And one can argue as to why, by watching, what if it's melanoma, then in 3 months it's going to be bigger, and then it may spread. Well, that's true, but the rate of growth is actually very slow. So it's not that it's going to double up in 3 months, and you're suddenly going to go blind from it. That's not going to happen. We know that pretty much. And the risk of spreading in 3 months would also be actually minuscule if you were to calculate. That's not more than 0, not more than 1, and not less than 0. So it's anywhere between 0 to 1%. Because the risk of dying from nevus is 0, and risk of dying from small melanoma is 1%. So even if it's melanoma, the risk of dying in 5 years from a small melanoma is only 1%. So if we are waiting for 3 months, if we're waiting for 6 months, the risk cannot be more than 1 and cannot be more than 0. So it's kind of in between somewhere. It's kind of, overall, I would say is minuscule. So to me, observation is also a good way. And up front, really, you want to take photographs, ultrasound, whatever testing we have to do to document it. So in the future, if there's a change, then you know that there's a real growth. If you don't have that kind of documentation, then you really cannot tell. If somebody makes a circle in a piece of paper and say, oh, you have a freckle, you don't know how big it is, you don't know what it looks like, you don't know what's on it or around it, then you really cannot tell. So a photograph, I think, is kind of the minimum necessary for the small tumor. So that's observation, therefore, built into that. And the medium-sized tumors, which has a broad range, was randomized to enucleation versus plaque radiation therapy. And the reason for this was that nobody knew at that time whether one treatment was better than the other. So you could, this is in 1980s, you could have gone to an ophthalmologist who would say, oh, you need an enucleation tomorrow, otherwise your melanoma is going to spread. And then you go to the other one, and he says, no, I can do radiation implant, and you'll be just fine. And the patient is thinking all the time, if I have radiation, the tumor is still there, what happens? Do I have a high risk of metastasis? So nobody knew whether one was better than the other. So therefore, NEI and NCI, National Eye Institute and National Cancer Institute, stepped in and said, we really need to figure this out. And only way you can figure this out is by randomization. So patients had a tumor of a certain size, so-called medium-sized tumor, and by pick of the, say, you have the eye removed or you have radiation. And that's very hard for a patient. Because the patient comes to me and says, Dr. Singh, what would I do? Or what would I recommend be done? So they're looking for my opinion, and I would say, no, I don't know. I'm going to press a button in the computer, And if it says 1, your eye comes out, and if it says 2, you have radiation. That is randomization. So there's a conflict, isn't it? The patient doesn't feel comfortable because you're not getting my opinion, and the doctor also feels unsatisfied because he's not giving his opinion. But if you keep giving opinion, then we'll never have the data, we just have the opinions. But somehow, they could collect 600 people who are okay with this, okay? And they randomized them. And they found out that they made no difference in the risk for metastasis. So at least that answer is settled. So whether you have eye removed or whether you have the radiation implant, the risk for metastasis is the same. So one can say that radiation is a good option, I can keep my eye, or you can say it was as bad as enucleation because it doesn't really help you live longer, for example. So then, what we are deciding, therefore, one over the other, is if this eye has vision or has a potential for vision, then we should do radiation to save the eye. And if the eye has no vision or no potential for vision, then you can remove the eye because there's no advantage of survival. Because at the end of the day, aim of treatment is survival. And if there's no difference in survival one way or the other, then it's okay. But eyes is not like, having your appendix removed or have your part of colon removed. It's this visible part of your body. Somehow you seem to be more attached to the eye than maybe other parts of the body. And psychologically, it's very difficult to say, oh, I'm going to have my eye removed, although it's a very safe procedure and very effective procedure with very low complications. And cosmetically, people look very well. They look very beautiful after the operation. But there is some kind of a psychological hesitation, let's say, for many reasons. And we understand that. But so in the end, as for then, I would advise somebody between the two based upon the potential for vision and whether this eye actually has normal vision. Some people, we have, for example, patient went for LASIK checkup and they found melanoma. His vision is 20/20 with glasses. So to tell that patient you have your eye removed is almost unacceptable because he actually didn't feel there was anything wrong with him because he didn't actually feel the melanoma. But if somebody has a hemorrhage from melanoma, can't really see within that eye, then they're a lot more willing to have the enucleation because they're already noticing deficit from it. Also depends what's happening to the other eye. If the other eye, the patient has only one eye, then your chances to do plaque are very, very high, obviously. And if you have, other eyes normal, then some people can say, I'm okay. And I tell you, we see patients in the clinic who are not able to come back for checkups because they live someplace 6 hours away, 5 hours away, and they say, just take my eye out because I'm not able to come back to drive to Cleveland or live in Cleveland or come back for all these checkups. So that's a real issue. That's a real issue. So that's how we decide between the two. But as for the survival, and we'll talk more about it tomorrow, there's clear data that there's no benefit one way or the other, and you're not losing any ground just because you have radiation treatment. Okay. But I do want to point out one thing here. Radiation treatment is highly effective in providing local tumor control. Our data for the last 5 years, 99% control rate. It's not published yet, it will be very soon. It's being statistically analyzed. But there's downside to it, that's loss of vision. In many cases, not right away, perhaps over many years, slowly, even as late as 8 years. In fact, we have a patient who had radiation therapy for a different tumor when she was 1 year old, and now she's 50 years old, and now she has radiation complications. She is a PhD here at Cleveland Clinic, and we did the laser to help maintain her vision. She has only one eye, the other eye was removed. So you can have radiation side effects. To me, that's the longest I have seen. I'm only 54 years old, so I can't really have a larger follow-up than that. But that's the longest follow-up that I've seen. So you can have radiation complications even many, many years later. To me, it's surprising. But typically in the first 2 or 3 years. But anyhow, so those are the two things. And you'll hear about new drugs that may provide equally effective therapies without toxicity of radiation. So we know radiation is effective. It's been known for many, many years. Radiation has been there from 1930s. And in the COMS, the control rate was 85%. We have, I think, we can claim very high, one of the highest in the country, let's say. So there is no difficulty about having tumor control in the eye with radiation. But the downside is, of course, the complications. And that's vision loss. And so there are other drugs that are being explored to provide, hopefully, equally effective treatments with low risk of complications. And you'll hear later on from Ellie and Allison. Okay? So there's something for after so many years, I'm grateful that there's something exciting coming in the field of melanoma. And the last thing I want to talk about is this large tumor. And they were randomized to radiation before enucleation, and we know that radiation actually made no benefit to the patients. And the truth of the matter is, and you will hear more about it tomorrow, that the eye is highly vascular structure. Tumor has a lot of circulation that's connected to the rest of the body. And pretty much in every case of melanoma, the cells are circulating. Time over, wind up. Yes, I'm winding up. So the cells are circulating in the blood in every case. Pretty much through different ways of research methods, we can prove circulating cells in the blood, pretty much for every cancer, for breast cancer, lung cancer. So eye is not the only cancer. But in some cases, those cells will take hold and become metastasis. And that depends upon two things, just in very broad perspective: how aggressive the cells are, how many mutations they have had, DNA changes, etc., and person's host defense mechanisms. So just because you have aggressive DNA or genetic testing, it's not 100%, because many people can even survive that. And we don't know why they're able to survive metastasis. We have a patient, I'm not sure he is here, who's had metastasis 8 years ago and is still alive and goes to work and comes to our clinic for checkups. So just because somebody has metastasis is not the end. There is something happening in their system we do not know. So we have taken many of his blood samples and frozen it, okay, because in the future, if we find something, we'll go and study it. So time to time, we'll ask our patients to give sample if we find there's something very strange happening to the clinical behavior. So therefore, doing radiation before removal doesn't help. It does not prevent circulation. Circulation is happening all the time. So to me, the basis for treatment or choice of treatment is driven by size, is driven by data, and this is as best as I can think of when I'm counseling my patients. So I'm going to stop here, and we take some questions.
Maybe I missed it. What under the large tumor, what is EBR?
Radiation treatment, external radiation before removing the eye. So there was a thought that maybe you could sterilize these cells by radiation, and then if you removed the eye, you would not spill the cells in the circulation. But that's been proven to be incorrect. So radiation is not used anymore before removal. That's external radiation.
Oh.
Not the brachytherapy, not the plaque radiation, but like the normal X-rays.
To get the conversation going a little bit, a question we get often through our forum is, there is often attributed to uveal melanoma micrometastatic disease that is already prevalent, circulating through your hepatic artery at the point of diagnosis. What do you tell patients? And is there a link between the size of the primary intraocular tumor and the risk of already having that micrometastatic disease going on?
Yeah. So that's a very important question, and I think one has to understand that by the time patients come to us with uveal melanoma, the cells are circulating and they're everywhere. And for whatever reason, we don't know all of it, it predominantly goes to liver. 90% of the time. If it goes anywhere, it goes to liver. You all know that. But why liver, we don't know that very well. But pretty much micrometastasis, this is microscopic cells, are there in every case. And in some, that micrometastasis will grow. So by the time patients are coming to us with eye tumor or eye melanoma, uveal melanoma, micrometastasis is happening. That is pretty much proven. I don't think there's any doubt about that. And we don't know exactly at what stage of growth that happens, but a few years ago, I did some mathematical calculations and it was published, and others have also done similar calculations. So it appears that the tumor is actually very small when the metastasis happens. Small means about the size of small, where you are unable to tell a nevus from small melanoma. So pretty much it's a very early event in development of melanoma. And although ophthalmologists felt for many years that we are curing patients with melanoma with radiation or removal, in fact, now we realize this is just a palliative therapy. You are only treating one part of the source. You're not treating the seeding, so to speak. And we're going to discuss that tomorrow, what attempts or what research is happening in that field. I have to say, because it's a rare disease and it doesn't attract that kind of funding or interest wide like we have for other cancers, the research is not happening that fast. But we all know that this is a limitation for many years. So micrometastasis is an early event. Pretty much one can say the tumor is about 5-6 millimeter in base, which would be along the size of a small melanoma. So if you can, theoretically, for example, say, if I treat small melanoma, you may improve patient survival. And I think that's one way to go forward. And in fact, that takes me to the next slide. So if we talk about small, medium, and large tumors, we know 5 years mortality with small is 1%, 10 with medium, and about 25% with large. So there is a clear correlation between mortality and size. So does the size matter? Of course it matters. So if you could treat every case when it was small, of course you're going to make a difference in outcome of patients. That's certainly one way to go. But the problem is you can't really diagnose a small melanoma very reliably because nevi are a lot more common, and nevi and melanoma can look the same. So if we talked about this equivalent, and then overall I also want to point out, based upon the national SEER data, we can see the enucleation rates are going down in America for the last 20 years or so, and the radiation rates are going up. So more and more patients are getting radiation because we know it does not increase the risk of metastasis. But the survival really has not changed. The graph is horizontal. So in 1970, somebody had melanoma, and now in 2010, somebody had melanoma. The outcome is pretty much similar, as long as the data. This is the data shows that. And so approach to reduce mortality, therefore, would be early diagnosis and early treatment. And then that takes you to how do you diagnose a small melanoma? That's kind of, Grant, your main question, right? How do you tell? So we know that some tumors like this, for example, may not change, and there's some that grow. So how do you know when you look at them for the first time, it has the potential to grow or not? And there are, at least in the medical literature, patients are confused, and so are all the physicians too. I think they'll use all kind of names for the same thing. You say, oh, it's atypical nevus, it's a large nevus, small melanoma, all kinds of names. Basically, I think we should just call it indeterminate. We do not know what they are, and just change the name. And we know in the size classification, if you look at the small ones, which is the COMS, you just change that to indeterminate lesions. So things that are from 1 to 3 or 1 to 2.5 now, and base 5 to 16, we call them indeterminate, and some of them are melanomas, and some of them are actually nevi, and there may be some intermediate we don't know. That's kind of where we are. And how can you tell? Well, if you look at the factors, if they're on the thicker side, if they're bigger side, and if there's orange pigmentation, lipofuscin, or subretinal fluid on it, then they're more likely to be melanoma rather than nevus. So it's a relative gradation. It's not 100% still. And that's kind of where we are stuck, because many patients have normal vision, and we're reluctant to do biopsies, for needle biopsies, for tumors that may be negative or may cause hemorrhage, may cause retinal detachment, and may not give an answer necessarily based on the cytology. So that's kind of where we are stuck with. as far as the small tumors go. And so we are looking at the photos. We talked about that. We look at the orange pigmentation. You see here very nicely how you can pick up the orange pigmentation, for example. It's the lipofuscin. We have new techniques to photograph it and to find it. We also use OCT, which is a optical CT scan, and you can pick up this lipofuscin orange pigment, what we call HLA granules, and this is just a little bit of early retinal detachment. So for us, something like this, nowadays, we would be treating it more than observing it because there's leakage here and there is orange pigmentation. And that's kind of, this is kind of one realm of discussion, small tumors, early metastasis, that we know is kind of well understood now.
I was just wondering if you could explain why it is not possible to surgically remove the tumor. Why do you have to remove the eye? Why couldn't you go in the eye and remove the tumor itself? Thank you.
So that's a very good question. Say, why don't you just go and surgically remove it? So number one, would be a complex surgery. So the tumor is under the retina, so you'll have to lift the retina up, cut the piece of the choroid, and put the retina down. Then the retina has nothing to be supported there, and so that would be an issue. If the tumor is in the macula or is touching the optic nerve, the patient is going to lose all vision. Okay, so smaller tumors tend to be near the visual structures because that's how they come to attention. Larger tumors, for example, we know that the surgical principles tell us that we shouldn't cut through the tumor. We should cut around the tumor. And there's no cancer anywhere in the body where you treat it by cutting through it. You always cut around it because you can track it, you can see it. You don't see it far away, but you see it where you touch it, where you cut it. So you really have to cut around it. So there are techniques of, say, for example, endoresection or resection. So there are tumors that are treated in the iris or ciliary body that can be cut out very nicely. So there are sites within the eye that can be safely cut upon, but not big tumors or tumors near the optic disc and macula. So those are uncommon, and we have patients here, I think we've treated for iris melanomas have been cut out. So, yes, sir.
I actually had a tumor on my iris in 1974. It was removed in 75. They took out 50% of the iris and the tumor. And unfortunately, the doctor that did it retired, and I switched doctors, different practices, and they weren't really following up on the potential. And then I was having trouble with glaucoma they were treating. Finally, in 2010, I lost sight. In 2008, I lost sight in the eye. And then in 2010, they decided it should be removed just because I was starting to have pain. And it wasn't until then they found a 2 by 2 by 1 inch tumor behind the eye. And then they did it, the surgeon then did an excenteration at that stage, followed by proton radiation. But I went basically 30 years without an apparent metastasization somewhere, which seems
is
to
excellent.
be unusual.
So again, iris tumors, the iris has a root called ciliary body, and the tumor can easily grow there unless you look for it by the ultrasound, for example. And that may happen, and you say, oh, the scar looks good with what you see, but there's a hidden component to it, which is very difficult to examine, and you can only examine by the ultrasound, the special ultrasound called
I think they did a P32 down.
Okay, well, that takes us to a prehistoric era. So,
It shows you can still get through it.
yeah. Well, I finished my training 25 years ago, and P32 test had been abandoned at that time. And I only read about it in one book and then never saw it again. But so the tumors can recur after many, many years, and that's the point. I think one has to keep that in mind. So melanoma, but one can also say that you had 30 years without trouble, but had it been followed, perhaps you could have found a small nodule. And so many patients, they say, do I have to come back again? I'm telling from my side now, okay? I can also say something. Do I have to come back again? It's been 5 years. It's been 10 years. Do I have to come back? And I said, I think you should come back once a year. You have a cancer, And if you spend 6 hours taking care of your cancer, what's the big deal? People are happy to watch TV for 6 hours every day. I mean, you can come 6 hours in a year for a checkup because the melanoma can come back. I mean, that's exactly your story. So now we have ultrasounds, and I know those ultrasounds did not come up till 1990s. The one I'm talking about, UBM, that looks at the ciliary body, that only was invented and came to market in 1990s. So in those days, they didn't have those kind of tests, and they wouldn't be able to find it. Thank you for sharing your story. Yes, sir.
I understand a few minutes ago you said that a choroidal nevus can be malignant even though it's not yet suspicious.
So that's a question of terminology. It's not choroidal nevus can be malignant. Choroidal nevus, if somebody labels it as choroidal nevus, then it's benign by the way you've defined it. But can it be a melanoma, which you think you're calling it a nevus, for example? The answer is yes. But that likelihood is actually very low because nevi are a lot more common and melanoma at that size are very few.
Is there any thought to a person that has a choroidal nevus going ahead and trying to get plaque therapy before just waiting to see if it ever turns into melanoma instead of just being a nevus?
So if you were to look at the definition of nevus and the prevalence of nevus in general Caucasian population, some studies say up to 5% of Caucasian population would have nevi. And yet we know melanoma is very rare, 4 per million or so. And we calculated one time the risk of it, a nevus becoming a melanoma, is 1 in 8,846, something like that. 1 in 10,000 in very simple terms. So that means you'll have to treat 10,000 cases to say 1 case of nevus becoming melanoma. That means you would have overtreated 9,999 cases to have prevented 1 melanoma. And in that process, many people would have lost their vision from some complication. So the key, I understand, because nevi, it's not like skin you can just shave off and be done with it. It's a very, of course, visually significant structure. So that's the issue. The nevi are so much common, melanoma is so much rare, and we don't have treatments that will, a laser that will melt away, for example, the nevus. Maybe in the future, maybe before I finish my career, there will be something that you can put a zap through and that we're done with it. But again, think about what you're going to achieve and how much will be the over-treatment. And this is just for nevus. I'm taking you to a different arena. You hear about prostate cancer. They say don't treat prostate cancer because nobody will probably die from it, or very few people will die from it. So that's a proven cancer. And the guidelines are that people are over-treating because you're causing more harm from a proven cancer. Here it's not even a cancer. So you have to really think about an overall situation as to you end up doing more harm, I think.
Within the ciliary body and the
choroid.
Does that increase the risks, or is it still just based on size?
The location is also a risk factor, we know that. Iris tumors have excellent outcomes, choroidal tumors have intermediate, and ciliary body have the worst outcome. Some of it is related to size, because ciliary body, like you mentioned, is a hidden part you cannot examine, and most of the ciliary body tumors tend to be larger by the time the patients come to us. Iris tumors, because they're external, they're a lot more visible, they tend to be smaller by the time they're diagnosed. But at the genetic level, when you were to do the DNA testing or RNA testing, etc., you would find that there's a clear difference between iris melanoma and ciliary body melanoma. They are genetically different also. So size is one, location, they're interlinked, and they're genetically just a little bit different from each other.
The second question is if you have an autoimmune disease also, does that have any bearing on risk for metastasis?
Yes. I mean, there are many kinds of autoimmune disease. So just in a broader sense, if you think about it, cancer cells are like bacteria or viruses. They are foreign cells, and the body is trying to fight them and get rid of it. Just not for uveal melanoma, just think very broadly. So people who have defective immune system get cancers. We know that. People who are HIV patients, for example, or who have a renal transplant or lung transplant, they are getting drugs that reduce the immune system and they get cancers. In fact, for renal transplants, they are dying more from those second cancers than from the renal transplant complications themselves. So they're living okay with a kidney problem, no problem there, but they're getting very aggressive tumors because their immune system is bad. So yes, any defective immune system would enhance that. But how exactly in uveal melanoma, because it's a rare disease, we can't really put those two together. But I know presence of autoimmune disease excludes patients for certain drug trials and things like that because they don't know how the immune system is working.
Since we don't really know why any of us got uveal melanoma in the first place, do we have to worry about the possibility of getting it in our other eye?
Okay. The risk is 1 in a billion. This is a short answer. There's a long calculation behind it, but answer is 1 in a billion. Yeah. In my clinic, we have only 2 patients who have bilateral uveal melanoma, and in both the cases, they had a freckle on the other side that we were monitoring, and that started to grow. So it just didn't start from anywhere. So I know we always check the other eye and worried about it and those kind of things, but chances are it will have other diseases, cataract, glaucoma, macular degeneration, normal things, rather than another melanoma. That would be very, very rare.
For people who have had uveal melanoma, would you say in general it's not good to have exposure to oral or intravenous steroid ever because that can temporarily, while you're on it, weaken the immune system? So if you had sciatica and someone said, we're going to do an epidural because you have a bad disc in your back, and would you say don't get exposed to anything that can weaken the immune system even temporarily?
I don't think so. That's I think stretching too far. Anything like I said, long term, for life you have renal transplant, lung transplant, something that you're having for life, that will have some bearing on it, but not episodic, 2 weeks, 3 weeks use of steroid for some illness or allergy or something else. That should be okay. Yeah.
This is a simple question. Since my tumor, optometrists, since they don't go through ophthalmology and all that, is there a push with this to teach optometrists to look for this more? Because my optometrist, he just happened, I'll put it as he put it, saw something bizarre pushing on my retina. But he really had never seen it before, never even, basically didn't really hear about ocular melanoma. So I'm curious if there's a push to teach just regular optometrists to look for this when they're doing dilations and so forth. Because that's what I kind of found out, that it seems like the optometrist is just such a rare cancer and they don't see it. And I think thankful that he did see it. But I'm just curious if there is a push to teach this more for optometrists to spot.
Yeah, every textbook has a picture of uveal melanoma in there. Every textbook of ophthalmology, I'm very sure. Okay, and there's no shortage of textbooks on uveal melanoma in themselves. So there's no shortage of material if people want to learn. Okay, you can go on Google and learn about anything that you want. Everybody is busy and they're tuned into what they normally see, dry eye, cataracts, AMD, that's what they're seeing all the time. And they are therefore kind of just limiting themselves to those things. And if it doesn't fit in with that, either they'll sit on it or refer to somebody based upon their own kind of concern for that. But I have to say that with the recent availability of these panoramic cameras that have, many opticians have that nowadays. So they may not be very good in examining the retina or fundus themselves, but after dilatation, they take a picture. And if the picture shows a little spot, they'll refer you to somebody else. They may not have noticed the spot on exam, but on the photograph that they take, they may see it. So I'd say there's some benefit of technology from there, but again, with that, you also get these false referrals and false positives and those kind of things. So there's no real answer. I know people should know about melanomas. We all know about some general stuff. They may not know about exact details of it, but if they see something new, they should certainly photograph it. Yeah, that would be the minimum. Photograph would be the minimum.
I think we have time for one more question, maybe two. Okay. So you know how you said spreading to your other eye is like 1 in a billion?
It's not spreading to the other eye.
Or
It's
getting it in your other eye?
arising in the other eye, yeah.
If I have 3 freckles in this left eye, does that mean like that's more scary or no?
Okay, so let me tell you. So risk of 1 freckle becoming melanoma is 1 in 10,000. So your risk is 3 times of that. So 1 in 3,333 is your risk of getting melanoma. How about that?
Okay.
Something like that. Very rare still, you know? Think about it. 1 in 3,000 is much lower than 1%. So
What is the current medical thought on whether the taking of a biopsy specimen during the plaque insertion increases the probability of metastatic disease?
no, it does not.
Does not.
It may increase our probability of local seeding, where the needle goes through and comes out. But if you're having it during the plaque therapy, then typically you go through the sclera, then that's covered. So that also is very low, but that would be the only risk. But for metastasis, it's through the blood supply. So needle biopsy does not increase that risk, no.
Thank you, Dr. Singh.